Hi, everyone, and welcome to our first webinar of the academic year. My name is Cindy Clowner. I'm with the Higher Education Center for Alcohol and Drug Misuse Prevention and Recovery. And we are so excited to have Dr. Lucas Hill and Dr. Lori Holleran Steiker joining us today to talk a little bit more about their program at the University of Texas Austin campus around opioid overdose prevention. Before we get started, we do have some housekeeping things that we would like to go over. First, we welcome your questions. They'll be answered at the end of the session today by Dr. Hill, and you can submit those by entering them into the question box in the right-hand control panel of your screen. We also encourage you to learn more about membership with the Higher Education Center, which includes access to our Screen U program. Screen U is a web-based screening, brief intervention, and referral to treatment program, and we've recently launched a new demo of the program, and so we encourage you, if you aren't familiar with Screen U, to take a look at that. You can view it at go.osu.edu/ScreenU demo, and of course, learn more about all of the membership benefits of the Higher Education Center at hecaod.osu.edu. And with that, it is my great pleasure to introduce to you our two presenters for today. Dr. Lucas G. Hill graduated from the UMKC School of Pharmacy and completed a combined residency fellowship in the UPMC Department of Family Medicine. He is now a clinical assistant professor and the Alumni Centennial Endowed Fellow in Pharmacy at the University of Texas at Austin College of Pharmacy. Dr. Hill is director and principal investigator of Operation Naloxone, an interprofessional opioid overdose prevention program funded through the Texas Targeted Opioid Response. His research is focused on clinician-community collaborations to address substance use disorders through evidence-based treatment and harm reduction strategies. Dr. Hill coordinates the first year of the UT Foundations for Interprofessional Collaborative Practice curriculum and leads the Embedded Addiction module. He provides an additional 16 hours of addiction-related instruction in the required pharmacy curriculum and precepts both the Overdose Prevention Service IPPE and Addiction Medicine Elective APPE. He also serves as faculty advisor for the UT Student Pharmacist Recovery Network. In 2018, Dr. Hill was awarded the Generation RX Champion Award for Excellence in Addiction-Related Education by the Texas Pharmacy Association and Cardinal Health. Dr. Lori Holleran Steiker is an addictions therapist turned educator scholar and a distinguished Steve Hicks Professor of Addictions and Substance Abuse Services at the University of Texas at Austin Steve Hicks School of Social Work. She is also the Associate Dean and Director of Instruction, Engagement, and Wellness for UT Undergraduate Studies. She holds faculty appointments at UT Dell Medical School Department of Psychiatry, as well as Baylor College of Medicine Department of Family and Community Medicine. She conducts federal, state, and foundation-funded research regarding substance use and misuse and substance use disorder interventions with expertise in community-based adolescent and emerging adult substance use recovery. She spearheaded overdose prevention and response initiatives on the University of Texas campus, helped start Operation Naloxone, and is a co-PI on the Texas State Opioid Response Grant to address the opioid crisis and prevent drug overdoses. In addition to her numerous awards and publications, she is also presently part of the executive leadership team of the SHIFT initiative to change the UT culture around drugs, alcohol, and wellness. Thank you both for being with us today.
Thank you so much for having us, and I know I speak for Lori and myself when I say that we're honored and excited that so many people have been willing to cut an hour out of their day to learn a little bit about this topic, and we're going to be certain to leave plenty of time at the end to discuss any questions that you have, and we will provide our email addresses on the final slide while that Q&A is going on so that you'll know how to easily reach us. We have communicated with many campuses across the country to try to support overdose prevention efforts and would be happy to provide some insight to you as well after the webinar. So I'm gonna take the first section and make sure that we're all on the same page about opioids, opioid overdose, and prevention of opioid overdose, so that when we talk about programmatic issues, it makes sense. So I'll leave the learning objectives up here for just another second for you so you can be aware of kind of the key points, the things we want you to be able to do after you finish engaging in the webinar today. And let me give some brief background on what an opioid is so that we're all on the same page. So opioids are derived from the opium poppy, which can legally be grown in the United States, but cannot be scored, because when you score the outside of an opium poppy, like you see here, a white milky substance comes out. If you're a Game of Thrones fan, you're probably familiar with milk of the poppy. So this is a substance that contains opium, and opium, the active chemical that we're talking about there is morphine. So actually around 1800, morphine was the first drug that was synthesized from a plant. You can see the chemical structure here if you're a pharmacology nerd. And morphine was utilized in a variety of settings, including battlefields for as a surgical anesthetic and a pain reliever. But some people became dependent, physically dependent, or developed an opioid use disorder around morphine. And a pioneering drug company known as Bayer Pharmaceuticals, the makers of aspirin today, decided that they could make a slight adjustment to that chemical structure and develop an even more potent drug that would be a good replacement for morphine if you had developed addiction, and would also be very potent and useful for pain control. And that was how they ended up sending free heroin to the homes of thousands of people in the United States, and marketing heroin for a number of years. Now, certainly, we know that that's not the case today, and we have a different approach to pharmaceutical use of opioids. However, it is true that from 2006 to 2013, generic Vicodin, hydrocodone, was the most prescribed drug in the United States. So certainly we still have a large amount of use of opioids, though typically through a much more regulated system. To be a little more specific on names, when we talk to students, faculty, and staff, we often find that people have some misconceptions about which drugs are opioids, and when we talk about overdose prevention, which ones we are kind of more focused on. So while a variety of drugs of misuse can contribute to an overdose or to long-term risk for harm, opioids have a really unique ability to cause an acute overdose, which is why we're more focused on those. And it's also kind of the one class of drugs where we have a really effective reversal agent that will work in the moment where the overdose is occurring. And I'll come back to that mechanism, but wanted you to be aware that even some drugs that we think of as really scary and things that we want our students and our friends and family to avoid, like say methamphetamine, are not opioids. We work through different mechanisms and do not directly increase that risk. So you're probably aware, you're a knowledgeable group, that drug overdoses have been increasing in the United States pretty steadily for about 20 years, and that they outnumber the number of deaths due to car accidents and guns, and more people die each year now from drug overdose than ever died in a single year from the HIV/AIDS epidemic. And that is an issue that, at least initially, was driven heavily by overprescribing of opioids, by readily available prescription opioids for misuse. However, that trend started to change around 2010, and there are a number of reasons for that, but it includes things like decreased opioid prescribing, increased use of prescription monitoring programs, searchable databases where prescribers and pharmacists can identify people who are misusing opioids and avoid prescribing or dispensing them, and the introduction of some tamper-resistant opioid formulations. And so we realized eventually, as a healthcare system, as individual providers, that there were risks here, and started to take steps to mitigate those risks. Unfortunately, as harm reductionists and many public health researchers could have predicted, this had unintended consequences. Anybody who's knowledgeable about drug policy recognizes that all drug policy tends to be a history of unintended consequences. So Instead of continuing to utilize medications like oxycodone illicitly, a large number of people transitioned to using illegally obtained heroin, and heroin overdoses from 2010 to 2013 increased by a more than compensatory amount. So the net public health impact here was actually probably negative in the short term from those attempts to reduce the supply of prescription opioids available for misuse. If we pull this data forward, we can see that this is going to be a shifting epidemic. Whereas the first wave was prescription opioids and the second wave was a move toward heroin, we now see that epidemic hardening further with an even more potent illegal supply of opioids, including fentanyl and other illicitly manufactured fentanyls. You might be familiar with fentanyl as a pharmaceutical opioid that is available in a patch formulation or sometimes in liquid or other formulations that are utilized primarily in hospitals. However, when we talk about fentanyl deaths in the United States, we're really talking about illicitly manufactured fentanyl, powdered fentanyl that is thought to be coming into the United States as an adulterant in the heroin supply from other countries, from Southeast Asia primarily. And you can see here from this picture the reason why an international drug cartel would want to switch to using something like fentanyl. It's 50 to 100 times more potent than heroin, meaning that you can ship a 50 to 100 times smaller package across a border or transport it between states or between individuals. So that has some huge advantages from that perspective. And to be honest, I think we've only seen the beginning of the fentanyl-related crisis. In some parts of the country, heroin has been completely replaced by fentanyl, including parts of the Northeast and upper Midwest. And so when we look at CDC overdose death data, we see that today we have more than 2/3 of all opioid overdoses are related to heroin or illicitly manufactured fentanyls, and that prescription opioids represent a relatively small piece of the pie. And without getting into more detail here, that line, the light blue line that shows the number of deaths due to prescription opioids is a bit misleading. It looks like it's continuing to increase, but if a person died with all three types of opioid in their body, they would show up on all three lines. And so realistically, many people who are categorized as dying from natural and semi-synthetic opioids, which are prescription opioids, are actually dying from an acute overdose of illicit fentanyl or heroin. They just happen to have some hydrocodone or oxycodone in their body at the time of death. One high point to hit here is that while we should be concerned about fentanyl has, there are many things to be worried about with fentanyl, including that it is increasingly showing up in other illegal drugs. We are seeing some cases of fentanyl being an adulterant in cocaine, in amphetamines. It is not showing up in all other drugs. There are no documented cases of fentanyl being mixed or sprinkled onto cannabis or marijuana, so that is something important to keep in mind. And additionally, so you may have seen some headlines stating that first responders experienced symptoms related to exposure, passive exposure to fentanyl, such as getting a little bit on their skin or under their nails when they were responding to an overdose scene, or that there have been incidents where several first responders have experienced symptoms and they thought that it might be because fentanyl had been aerosolized and they were breathing it in at the scene. I want you to know very clearly and definitively that those things are not possible. And while I don't want to impugn any of those first responders, because there were a couple of very highly publicized stories early on in this fentanyl crisis a couple years ago. They have led to widespread belief among some first responder groups that passive fentanyl exposure can be deadly. And thus what we're really seeing in those cases, if we look closer beyond the headlines, are cases of severe panic and physiologic reactions to the extreme psychological stress of believing that you have a killer powder on your skin or around you. And so I just want to make it very clear that there is no need to delay overdose response. There is no risk when you are responding to an overdose that if you get a little fentanyl residue on you, or that if you breathe in enough air, that you will absorb any fentanyl or be harmed by it. That cannot happen. And I'm happy to provide additional links and resources to supplement your knowledge in that area, or to convince anyone that you might need to convince on your side. While we don't need to worry about putting on a hazmat suit and a respirator when we identify an overdose, there are a couple things we need to be prepared to do on our campuses so that we can save a student or staff or faculty member or visitor. And those things include having someone who's knowledgeable, hopefully, about identifying an opioid overdose, going through the key steps of trying to rouse them and calling 911. And most importantly, excuse me, I'm having some slide issues. To be able to administer naloxone. So the reason that a person might die from an opioid overdose is the lack of sufficient oxygen in their body. When an opioid is attached to certain receptors in your brain, it shuts down your intrinsic drive to breathe. And so a lack of oxygen is really what is causing death in a person who experiences an opioid overdose. You could potentially provide rescue breathing to save that person, but rescue breathing is actually quite difficult to sustain for a long period of time. And I can say, after taking both a general basic life support course and basic life support for healthcare professionals, it's generally not a skill that is taught or practiced in any of those courses. And so I wouldn't feel confident that I could do it, even though I educate others on it regularly, which is one of the reasons why naloxone can be so essential to have on hand. So I mentioned that when certain opioid molecules, let's say this is a molecule of heroin, the blue circle floating around in your body, when they attach to opioid receptors signified by these green lightning bolts, they provide pain relief. And they can also, depending on where those receptors are located, when they're activated by an opioid like heroin, they can cause other side effects like constipation. Specifically, when they attach to those receptors on the brainstem, they can shut down that intrinsic drive to breathe. And so while a person may not be breathing sufficiently or not breathing at all, but while their heart is still beating before they've completely run out of oxygen, we can save their life by getting naloxone into their body. Naloxone signified by these little green circles. Naloxone can be squirted into the nose or injected into the muscle. And within about 2 to 3 minutes, it should find its way to these receptors. It will essentially knock the heroin out of the way, attach to that receptor, but without activating it. So naloxone is what we call an opioid antagonist, or an opioid blocker. It does not activate those receptors. It does not cause pain relief. It cannot be misused. It does not cause euphoria. Similarly, though, it doesn't cause any harm in a person without a physical dependence on opioids. If I am someone who doesn't use opioids and I squirt a little naloxone in my nose right now, nothing will happen. I will have no side effects, no experience whatsoever. A person who uses opioids on a regular basis will experience opioid withdrawal, which is extremely uncomfortable, but almost never life-threatening. It is important to call 911 and get supportive medical services, but certainly any risk associated with naloxone is far less than with being unable to breathe. Naloxone will only last in a person's body on average for about an hour. Many opioids can last much longer than that. Again, a key reason why we need to get emergency medical services involved in case additional doses are needed. There are 4 types of naloxone that are appropriate for non-medical individuals to use. And they are all depicted here, spanning from a very cheap vial and intramuscular syringe for injection, all the way to an auto injector that talks when you open it up, and then with a retracting needle. We tend to utilize on our campus Narcan nasal spray, which costs $75 per box directly from the company. It's a box of 2 doses, and we find it to be a pretty good combination of ease of use and relatively reasonable cost when you compare it to the most expensive option. But really the best naloxone is the one that you can access, and so any of these versions works just fine, and no version has been proven more effective than any other. Naloxone access laws, which increase access to naloxone, have been passed in all 50 US states. If you are not familiar with the law in your area or you're looking for more specifics, I would encourage you to go to the link included at the bottom of this slide. The Network for Public Health Law has also been extremely helpful to us in bouncing questions off of them, any concerns that we've had from administration, to just make sure that everybody was on the same page and felt okay about how we were implementing our program. But really, these laws make it very easy to possess and distribute naloxone. In Texas, we've got a pretty broad naloxone access law. We're able to put naloxone in all kinds of places on campus, have students distribute it at public trainings with no problem. We have no liability issues because the law explicitly provides very broad liability protections. So I've given you a background on what naloxone is, what opioids are, and kind of how those two things interact and why we should be concerned about them. And now I'm going to turn it over to Lori to talk a little bit more about how this applies specifically to college students and why it's so important.
Thank you, Lucas. So I think it's important to recognize that every campus has a unique community and a unique culture with different resources and different processes around implementing such a program. So I'm going to start by saying a little bit about sort of how we geared up for Operation Naloxone, to talk about the kinds of things that we did to create the community of care around opioid response. We started with breaking down silos between the folks that were working in the area of opioid response, starting to build connections between pharmacy and social work, for example. And a critical piece in the puzzle was getting our community experts involved. So our local coalitions around opioid response, and particularly in Texas, we had a nonprofit called Texas Overdose Naloxone Initiative, who had already started the process of leaning into policies and naloxone acquisition and distribution in surrounding the campus. And so the most interesting part of the story for me is that because of stigma and the language around substance use disorders and opioids, and because of the way that people are it's a steep learning curve when it comes to understanding the nature of opioid use disorders and how to intervene, that we actually found out about several student deaths over a winter break from our community partners. And these are not like when there's a murder on campus or a suicide on campus where it winds up in the media quickly. These are incidents that tend to be very secretive. Families do not want to disseminate the information, and campus folks may not even know it's happening. So while you may feel like you want to be proactive and prescient, it's important to know that because of the statistics around opioids presented by Dr. Hill, there is an urgency to having these processes and available resources and educational components on campuses, even if it feels like opioids are not prevalent or an issue that you would notice. So I think that that's an important thing to start off with as a foundational caveat. Oh, and let me say that our Operation Naloxone, I know that Dr. Hill will return to speaking about it and its resources, but it is available for anyone that would like to access training and more information, and it even has places to ask questions and figure out how to get the actual naloxone on your campus. So I do hope that this is a resource that you will utilize. So what does it look like on college campuses with regard to opioid misuse and opioid use disorders? We need to note that previous to what was identified as an epidemic, I like to say that it was a hidden epidemic prior to that because it wasn't hitting the demographics that tend to draw the media in the way that, and I'll be very specific since I'm a social worker, it was an issue that was related to communities of color and poor communities. But between 1993 and 2005, the percentage of college students using and misusing prescription drugs increased exponentially. And the numbers continue to rise. Some of the research, the Clinton Health Matters Initiative in 2014 saw a 343% increase in opioid use, and that is partially due to availability, partially due to some of the historic factors that Dr. Hill mentioned. And I think that there was this sense also that when you talk to students about this, they say, well, things that are prescribed by doctors tend to be safer than things that aren't. And so that was sort of a myth for a while that there was a safety in using opioids. I think it's important to know that about 50% of the college students are offered a prescription drug for non-medical use by their sophomore year. So there is definitely an prominence in availability, and it's most prevalent among highly selective urban colleges. And in surveys, college students who took an opioid for reasons other than pain relief had a much greater risk of experiencing 3 or more drug use related problems. So, that while we are noting that students that are in need of perhaps secondary or tertiary interventions, prevention interventions, that is, they're already at risk or already using or already in trouble with opioid use disorders. Some communities just haven't called it out enough for students to know that they can reach out for resources. Persons aged 18 to 25 are more likely than any other age group to have misused a prescription drug in the past year, to have used any illicit drug in the past month, and to have used heroin in the past month. In Texas, while most people associated heroin with intravenous drug use, there were various forms of heroin that became much more accessible to young people. Heroin in powder form, black tar heroin, which comes as like a sticky, dark substance that gets mixed with liquids and sometimes smoked, sometimes inhaled, sometimes eaten. And so there's a variety of mechanisms for heroin use that you might not see and might not assume are prevalent because you're assuming it's intravenous drug use. Let me talk a little bit about the diagnostic criteria for opioid use disorder or substance use disorders in general. We used to talk about diagnosis as something that was dichotomous. Either you had an issue with substances or you didn't. And so we used to think of it like pregnancy, either you is or you ain't. But the truth is that there are various severities of substance use disorders, mild, moderate, and severe. And so it's important to consider that there are different criteria related to different prevention and intervention procedures. So I kind of want to call out what those criteria are in a general way. Recurrent substance use resulting in a failure to fulfill roles and obligations is one. Recurrent substance use in situations in which it's physically harmful or hazardous, such as driving an automobile or while impaired. The third criterion is continued substance use despite having persistent or recurrent social or interpersonal problems caused or exacerbated by the effects of substances. Tolerance is a diagnostic criteria. It's important. Sometimes people think that if you don't have tolerance, that's a make or break it kind of symptom, but the truth is that it is not in itself diagnostic. So having a need for increased amounts of the substance to get the same desired effect, or diminishing effects with continued use. Withdrawal as manifested by either characteristic withdrawal symptoms for the substance, or the same substance is used to relieve or avoid withdrawal symptoms. The sixth category is the substance is often taken in larger amounts or for longer periods of time than intended. So one's life starts wrapping around the substance. The seventh is there's persistent desire or unsuccessful attempts to cut down or control the substance, or even stop using the substance. I think that's a really important tool, because it's a great question to ask somebody when they're struggling with this is, have you tried to cut down or quit? A great deal of time is spent in activities necessary to obtain the substance. Important social, occupational, and recreational activities are given up or reduced because of substance use. The substance use is continued despite the knowledge of having the persistent or recurrent physical or psychological problems. And finally, that craving or strong desire or urge to use the substance is part of the picture. So 2 to 3 criteria may indicate a mild substance use disorder, 4 to 5 a moderate substance use disorder, and severe is 6 or more of the criteria. And I think it's important to note that craving is misunderstood in a lot of categories. In a lot of settings, because people think that craving is, I've eaten 1 or 2 potato chips and I finished the bowl, that must be craving. I think it's important to note that this is a disease that originates in brain chemistry, and that the craving occurs in the part of the brain that triggers instincts like fight or flight, or the instinct to eat or drink or procreate. So this is experienced by the person with the substance use disorder as a need, and that there may be desperation related to that use. So we talk about the importance of how we communicate around addiction. Even the word addiction is misunderstood in many different ways. And Carlton Erickson, who wrote the book, The Science of Addiction, a little commercial there. He is a pharmacy professor emeritus out of UT Austin. He likes to talk about big A and little a addictions, because there are process disorders that have an obsessive compulsive component to them. But when we talk about addiction as a brain disease with regard to substances, it is very different than talking about an addiction to Oreos or an addiction to shopping. So I think that that's an important piece in what we need to talk about. So the language that we use is really critical. It can make or break the difference in whether or not we're able to convince administrators to address these issues on campus, as well as whether or not we're able to be convincing someone who is in the throes of a substance use disorder sitting in front of us. So regardless of the setting, we want to use person-first language whenever we can. So rather than calling someone an addict or a junkie or a druggie, using words like person with a substance use disorder. The example I always give is we don't call people with eating disorders food abusers. I think that would have all kinds of strange connotations. And so we want to be very careful about our person-first language. And a person living in recovery, as opposed to an ex-addict, is a better frame, and it celebrates somebody's ability to change their life towards wellness. A person arrested for drug violations is better than drug offender. And so anything that might tend to ostracize or put somebody in a category or define a person wholly around their behaviors, I think should be avoided. A person who, I think, too often when we're in therapeutic settings or even in advising settings or even professors, we tend to see somebody that's not getting help as quote unquote non-compliant or unsuccessful. And I think it's important to recognize, especially now that there's incredible research around the stage of change model, that may mean that a person is not at a stage of readiness. There are still very effective interventions. And so for those of you that are curious about those, you might poke around or get some training in motivational interviewing. Thinking of medication as a treatment tool as opposed to a crutch is critical when it comes to opioid use response, because we have just immense amounts of research that show that medication-assisted recovery is not only viable, but very often the treatment of choice for people with opioid use disorders to be successful in their recovery. Having a setback as opposed to relapsed. Relapsed, of course, puts the blame on the person. It has shame attached to it. Having a setback, very often I work with young people at the recovery high school. A lot of times their relapses or their recurrence of symptoms is what actually catapults them into greater commitment to having, to utilizing the tools, to increasing their recovery capital and to moving in the right direction. Maintaining recovery as opposed to clean, keeping clean. I think this is really important, and positive drug screens as opposed to dirty drug screens. The use of the words clean and dirty are incredibly judgmental, and I think it's important for us to recognize that all of this is part of our ongoing struggle with how to recognize that somebody with a disrupted pleasure pathway may not have an easy road to recovery, and that there's not just one pathway, there are multiple pathways. So let me get back to talking about how we compiled the team, and then I'm going to hand it back to Lucas in just a few minutes. We found that on the 40 acres at the University of Texas, that we had some incredible prevention interventions coming out of our student affairs territory. We had a wellness network that actually included an underage drinking committee. It included, we built, when we were starting to develop Operation Naloxone, a response team. It was a task force that actually became a standing committee called COSOP, the Committee on Substance Safety and Overdose Prevention. Of course, I've mentioned our UT School of Pharmacy, and I've also mentioned the Steve Hicks School of Social Work. So there are a variety of departments. We also have a medical school, the Dell Medical School on our campus, which houses something called the Wagner Center, which studies brain research around alcohol use and substance use disorders. And we have a Center for Students in Recovery that's an award-winning center that actually our regents have supported for years. I think we're one of the only campuses that has disseminated to our CSR to all 9 UT campuses. We have a very strong and award-winning UT Students for Sensible Drug Policies who have really made a difference in our areas of amnesty and policies related to these things. They've also been very powerful with our student government in leaning in around opioid response. Our UT Police Department was not only amenable to opioid response, but really hungry to have connections with the agencies and the experts on campus. We actually, Chief Carter had witnessed someone that he came on the scene, thought the person had died, was basically writing up the paperwork, and the EMTs came and administered naloxone, and the person sat up and had a conversation with him. He was struck by that experience and wanted to make sure that all of the police on the UT Police Department had naloxone on board, and Operation Naloxone did that training, which was very powerful to lean in on campus and enhance the relationships in the necessary areas. The UT Housing and Food Services was critical in terms of making sure that our resident assistants were trained, and our initial training did not include naloxone. They weren't ready to administer naloxone in 2015, but with further education and bringing pharmacy on board and the availability of our naloxone and our trainings, we've gotten to the point where we have naloxone available on every floor of every dorm. Every RA is trained on campus, and RAs off campus, as well as co-ops, have engaged in the training as well. So I want to drive home how important it is that you do as much as you can to build partnerships on and off campus so that you can get the needs of your campus met. And in terms of accessing naloxone, for us, donations have been secured from our community harm reduction organizations via the manufacturers, as well as, and we've been able to provide free Narcan nasal spray, and that is available to other colleges and universities. And I think Lucas in a moment will say more about the particulars of that. We're very proud to be utilizing Nalox boxes, which I think are placed on some campuses right next to fire extinguishers as a harm reduction technique, which we feel very strongly about. We know that the lock on it is misleading. We do not keep our naloxone locked up. We wouldn't want somebody to be fumbling for a key and the need for that. But I think it's important for us to say that it puts the RAs at ease, that there's been no pushback at all of having this disseminated across campus. If anything, our student affairs, our faculty, our students, our administrators breathe a sigh of relief that we are ahead of the curve on this. So I really encourage you and your campus to get busy and utilize our resources and build on them from your campus culture's perspective. So Lucas is going to share a slide that has my email address on it. I am always available to answer questions if there's anything particular related to social work and the models that we have from a psychosocial perspective. And I'm going to pass the baton back to Lucas to continue presenting.
I appreciate the perspective, and then also just the opportunity to contribute at the university that really was all facilitated by Lori, and her maybe greatest skill is convening key people and making connections that lead to really positive outcomes. And I think this program is an example of that. So let me give you a couple of key details about how we implemented the program and the outcomes that we've seen so far before we switch to Q&A. This picture, this slide depicts two of the primary ways that we initially sought to expand naloxone access, and the two ways that I think most campuses are discussing. And I'm going to preview the results here and say they are not the two most important things to do by any means, but we certainly thought they were good. One was to train all of those police officers and give every one of them a dose of naloxone so that they would be able to administer it if they happened onto an overdose. They're always available. They've got a quick response time. And the other was to implement those naloxone boxes inside of the dorms, residence halls, and to start training every resident advisor and every residence hall staff member in overdose response. And we've been did both of those things starting in the fall of 2016. And we feel like those were important first steps. But the most effective thing that we've done was to initiate broad open trainings on campus, and these occurred through a pharmacy student service learning program. So starting in that first fall, at the same time we were doing these other trainings and making naloxone readily available, we also began training pharmacy students to go out and do outreach trainings to peers, to other university students, and especially go to off-campus housing locations where we thought drug use might be a bit more normal and the risk for overdose might be a bit higher than, say, in a on-campus residence hall or lecture building. And we certainly found that has been the case. We have been providing these trainings, both in-person trainings led by pharmacy students and tabling at open events, distributing naloxone at all of these trainings for 3 years now, and I can proudly report that we have received reports of at least 5 lives that were saved by UT students who were equipped with naloxone that we distributed to them. And this is really something that's borne out in public health and overdose prevention research again and again. And that is that the real first responders in an overdose are other people who use drugs. The person who can respond the quickest and avoid negative outcomes is someone who was there when the overdose occurred, not someone being called later. Additionally, there's good evidence showing that the majority of overdoses that occur, the person who is with them at that time is not going to call 911 because of fears of prosecution. Even if your state has an overdose Good Samaritan law, which in theory would protect someone who's using drugs for calling 911, as long as they're trying to save their friend, even if they had been using as well, even in those states, we are seeing an uptick in the number of prosecutors who are charging both the overdose victim and the person who called 911 with severe long-term incarceration related to that call. So those are not a useful security blanket. And we know that in some of these cases where naloxone was utilized that we distributed, 911 was not called. And that person likely would have died had we not given access. Meanwhile, while we're certainly think that training police, equipping them, training residence hall staff, equipping them, making naloxone readily available in lecture halls, that's all good and nice, but in reality, it has not led to a single overdose reversal on our campus in 3 years. Now, it's not that expensive when we talk about just replacing naloxone inside of the boxes in the residence halls. And I think that we could potentially have utilized some of those or some other locations on campus if we did a better job of proactively advertising them. Maybe it would have more of an effect. Maybe the fact that we've made naloxone so readily available in public trainings where people who are at risk of experiencing or witnessing one, they're just able to get it for free from us and already have it on hand. Maybe if we didn't have that, then stocking in the residence halls would be more effective. But the reality is that ultimately, the most important first step if you want to decrease overdoses on your campus, and this is supported by our experience, our publication, and all of the public health research related to opioid overdose prevention, is to just get naloxone out into the hands of people who know they are at risk or know that they know someone else who is. So that's my bottom line, key thing that I want you to take away. Now, please, I'm open to any sort of question. If you've got concerns about what happens in an overdose situation, questions about specific policies, throw anything at me, and I'm happy to entertain that until we run out of time. Thank you so much for signing on, for staying on, and please do email us if you've got to take off or if your question doesn't get answered.
Well, thank you so much, Dr. Hill and Dr. Holleran Steiker, for sharing your expertise with us. I do want to apologize to both of you and to the rest of you that are joining us for our technical difficulties today. You know, we prepare for technical difficulties. We don't prepare for power source difficulties, and so we apologize for that and appreciate all of you sticking with us. It is the time for questions now, so we encourage you to send those our way by putting them in the question panel on your control panel. We'll be posing those to Dr. Hill in a moment. Before we do that, we do have a couple of housekeeping things as those questions are coming in. We just wanted to let you know about our upcoming learning collaborative because it's very much in line with our topic of our webinar today. Higher Education Center Learning Collaboratives are a series of web-based trainings around a specific topic, and this fall's learning collaborative is around harm reduction. It's looking at it from a more comprehensive perspective, and so not focused solely on opioids, but still looking at it from a college lens. And so we'll be sending out additional information about the dates and how to access that learning collaborative soon. And our Higher Education Center members receive free access to that learning collaborative. So stay tuned for that. Additionally, we want you to be marking your calendars for August 3rd through the 6th for the 2020 national meeting, which will be taking place here at Ohio State's campus in the Ohio Union. And so call for proposals will be going out for that here in the next month or so. And we hope to see all of you in Columbus next summer. And so with that, we do have some questions coming in. Dr. Hill, we got some questions way back at the very beginning when you were talking about fentanyl. And so maybe we'll start there. You had referenced that there are some other drugs that you have seen fentanyl mixed with. Could you share a little bit more about what those are?
Absolutely. So the evidence is limited on this particular issue, and it's very difficult to parse out what is real and what is hysteria. And anytime that we've got a new drug-related issue, certainly we're going to have a fair amount of hysteria. So I think maybe the most compelling evidence showing that at least some samples of cocaine and amphetamines are containing fentanyl is that some harm reduction groups, some needle exchange groups, which they're typically not too quick to buy into drug-related hysteria, they have been using fentanyl test strips to help individual people who use drugs identify whether or not ultra-potent opioids are in their drug sample so that they can use differently. They can use less, they can use more slowly, other harm reduction mechanisms. And they have reported that they are seeing increasing rates of cocaine and amphetamines, which are testing positive for fentanyl. I also recently was working with a local harm reduction coalition here in Austin. We are down south in Texas, where a lot of people think fentanyl can't penetrate because we have a different kind of heroin that's harder to mix with white powder. And clients of that needle exchange were actually telling me, I don't need any fentanyl test strips today. There's no point, everything tests positive, even things that I don't think are supposed to be opioids, like cocaine. Now, whether that's a small amount of cross-contamination or whether that's really an amount that would cause someone to be harmed remains unclear, but cocaine and amphetamines would be the highest risk. Again, no documented cases of cannabis being adulterated in any way with an opioid. But it's a reason why even on campuses where we know that misuse of prescription opioids has actually been decreasing a bit recently, we know that kind of college-aged individuals are at risk for using heroin, but that risk is certainly higher among non-college peers. Well, we still know that college students are using things like cocaine, are using different kinds of pressed pills, maybe using benzodiazepines, like Xanax. And there are times when we've seen pills that are actually counterfeit, that are marketed as being Xanax when they're sold to an end user, but which are actually a pressed pill, a fake pill that includes things like fentanyl. So this risk for ultra-potent opioids being inside of other drugs is another reason why we should keep in mind that having naloxone around just in case is really important, even if we don't think that our students are likely to be using heroin.
Great, thank you. In addition, we got some, really positive feedback when you showed your graphic around kind of the myth about the impact of touching fentanyl leading to overdose. And there was interest around where you might be able to find some additional resources to support that, particularly in communities that maybe have had some of those cases supposedly happen within them.
If you go to our website, operationnaloxone.org, and you click on the fentanyl tab, you will see a few key resources, including one position statement from the American College of Medical Toxicology, another peer-reviewed publication talking about first responder safety, and like smart people tend to do, they hedge a bit. They recommend that you still utilize caution, that anytime anybody's responding to a medical crisis, they wear gloves, not because of concerns about passive fentanyl exposure, but concerns about blood-borne diseases. And those are all reasonable recommendations, but they are clear that this risk of passive exposure is overblown. And I would go a step farther and say that as a pharmacist, pharmacy professor, I know that the fentanyl patch, which is specifically formulated, millions of dollars spent by a pharmaceutical company to help this patch deliver drug through a person's skin. Even when you put on a fentanyl patch, you feel nothing. You feel no opioid effect for 6 to 8 hours. And yet, if you look closely at these reports, you'll see that individuals who may have been exposed to fentanyl powder on their skin, and powder's no way to deliver medication across the skin, by the way. We never do that in pharmacy. That when they have just a few seconds or a minute of that, are experiencing symptoms. And those symptoms tend not to be anything similar to what an opioid overdose would sound like. So an opioid overdose would be characterized by being non-responsive, having slow breathing, becoming moving or speaking very slow. And alternatively, what you see in these instances is tachycardia, rapid heart rate, severe anxiety, a sense of impending doom, all things that are consistent with a panic attack or severe psychological reaction to that kind of stress. And additionally, in many cases, the first responder will administer naloxone to themselves. If you can administer naloxone to yourself, you are not experiencing an opioid overdose. So again, I don't mean to impugn or speak negatively about any of these individuals. I do not blame them for that reaction, but it is vitally important that we keep good, accurate information out in our communities, because we have already seen documented incidents of first responders delaying overdose response so that they could put on a respirator or a hazmat suit, and the risk for severe harm to the overdose victim, or even to causing their death because of that delay, is very high.
Thank you. So Dr. Hill, let's say some of these campuses are interested in beginning conversations around starting a program like this on their campus. What kind of recommendations would you have for them in terms of how they should go about that, and who should be the people they should be having those conversations with?
Every state Department of Health is receiving federal block grants from SAMHSA, the Substance Abuse and Mental Health Services Administration, numbering in the tens of millions of dollars typically, to increase opioid use disorder treatment and to expand access to naloxone. So there should be a more or less unlimited supply of naloxone available through your state Department of Health. They may be subcontracting with another unit. So if you're not already aware of where you can access that free naloxone, reach out to someone at your Department of Health, your Health and Human Services Commission, etc. Additionally, if you've got a health professions school on campus, they could be a great resource to provide training, a pharmacy school, a medical school, etc. But I will also add that one of the things that was really helpful to us initially, and would be very helpful, especially if you don't have a health profession school, would be to find your local harm reduction coalition. They tend to be the true experts in this area. Even more so than pharmacy and medicine, harm reduction coalitions have been distributing naloxone for decades, oftentimes before it was technically legal to do so. And so they have that lived experience to understand what it's like to actually administer naloxone, how an opioid overdose will present in real life. They can be very helpful. Additionally, on our website at operationaloxone.org, under the resources tab, we have a sort of a draft policy for a campus talking about key things that should be prioritized. But again, at the end of the day, if you could talk to your local harm reduction coalition, host an on-campus training, help to publicize it, and distribute naloxone at that training, that would probably have a bigger impact than almost anything else you could do. Individuals who are at risk or who know someone who is at risk, they will come to that training if they know it's available, and the doses of naloxone that you distributed will have the highest likelihood of actually being utilized.
Great. Dr. Hill, do you have time for one final question?
Absolutely.
Okay, I think this is an important one. We have a question about, do you have any tips or talking points that you could share that those in attendance could use when speaking with college administrators about why providing naloxone training is so important?
I think it can be dependent somewhat on the questions and pushback that you receive, but I will say that I think there are probably two key documents that might include what you're looking for. First of all, I would say the first reference, the top one listed at the bottom of this slide, our paper implementation of a collaborative model for opioid overdose prevention on campus, and that being published in a peer-reviewed source that was is specifically for college health administrators could be really helpful. It reviews some of the key findings that I discussed with you today. And then if you go to operationnaloxone.org, you click on resources, there is an educational packet. It's 3 pages. It might include some things that are less pertinent on campus and that are more healthcare provider directed, but it also throws out some kind of key myths or key questions that people without a lot of specific training in this area often have initially, and addresses those in an evidence-based manner. And so I hope that that would be useful to you in most situations.
All right, well, Dr. Hill, thank you so much for being with us today and sticking around to answer those questions. We want to thank Dr. Holleran Steiker as well for sharing your expertise and knowledge around this initiative as well as the program that you've implemented at UT Austin. Thanks to everyone else for joining us, and we hope to see you at our next webinar that'll be happening in November. So keep your eyes peeled for your emails so that you can get registered for that when it goes live. Thank you, everyone. Have a wonderful day.